Welcome to listen to the topic Medication Use Process. Medication use process provides the conceptual framework for investigating activities associated with the use of medications. It enhances the roles of pharmacists and technicians as advocates for the proper use of medications. It leads to quality improvement activities designed to decrease the number and severity of medication errors. The steps of the process. Firstly, prescribing, which is done by physician, nurse, or pharmacist. It consists of patient evaluation, establishing the need for medicine, selecting appropriate medicine, drug regimen determination, medical record documentation, determination of interactions and allergies, prescribing the medicine, and ordering the medicine. Secondly, transcribing, which is done by pharmacist, nurse, or unit clerk. Receive order, check if it's correct, transcribe prescription and order, transmit to pharmacy. Dispensing, which is done then by pharmacist. Review prescription order, confirm prescription if necessary, contact prescriber for discrepancies, prepare, mix, compound the medicine. Pharmacist double check and dispense to the unit. Administering, which is done by nurse. Review prescription order, confirm transcription if necessary, review warnings, interactions, allergies, evaluate the patient, administer medicine, and document. Monitoring, done by nurse, physician, and pharmacist. Assess therapeutic effect and adverse events. Review laboratory tests. Treat adverse events if occurring. Report and document results. And definitely provide feedback. Medication reconciliation. Medication reconciliation is the process of comparing a patient's medication orders to all of the medications that the patient has been taking. This reconciliation is done to avoid medication errors such as omissions, duplications, dosing errors, or drug interactions. It should be done at every transition of care in which new medications are ordered or existing orders are rewritten. Transitions in care include changes in setting, service, practitioner, or level of care. What's the background and importance of the medication reconciliation? According to the Institute of Medicine's Preventing Medication Errors report, the average hospitalized patient is subject to at least one medication error per day. This confirms previous research findings that medication errors represent the most common patient safety error. More than 40% of medication errors are believed to result from inadequate reconciliation in during admission, transfer, and discharge of patients. Of these errors, about 20% are believed to result in harm. Many of these errors would be averted if medication reconciliation process were in place. What are the steps of reconciliation process? Develop a list of current medications. Develop a list of medications to be prescribed. Compare the medications on the two lists. Make clinical decisions based on the comparison. Communicate the new list to appropriate caregivers and to the patient. The safety and vulnerability of the medication reconciliation. Various factors, such as patients' lack of knowledge of their medications, physician and nurse workflows, and lack of integration of patient health records across the continuum of care. They all contribute to a lack of a complete medication reconciliation, which in turn creates the potential for error to occur. Physician and nurse workflows have not traditionally included making a regular inventory of all medication the patient is taking, including the prescription medications, over the counter drugs, herbals, and other complementary drugs such as vitamins, or verifying these lists with the patient. There has been no standard regarding what constitutes a comprehensive medication history or where medication information is kept in the paper or electronic health record. A patient's medication history may be found in the nursing admission database, the medication administration record, the physician history, and the pharmacy profile. When healthcare information is not integrated across settings, organizations, and among clinicians, it is not easy to validate or fill in the gaps from patient-reported information. Patients and family members may not be good historians of a medication record, and due to limited access to pharmacy records, only an incomplete recording of current medications may be obtained. Types of errors in the medication use process. Prescribing error. Incorrect drug selection based on indications, contradictions, known allergies, existing drug therapy, and other factors. Dose, dosage form, quantity, route, concentration, rate of administration, or instructions for use of a drug product ordered or authorized by physician. Illegible prescriptions or medication orders that lead to errors that reach the patient. Omission error. The failure to administer an ordered dose to a patient before the next scheduled dose, if any. Wrong time error. Administration of medication outside a predefined time interval from its scheduled administration time. This interval should be established by each individual healthcare facility. Unauthorized drug error. Administration to the patient of a medication not authorized by a legitimate prescriber. Improper dose. Administration of a dose that is greater than or less than the amount ordered by the prescriber or administration of duplicate doses to the patient. For example, one or more dosage units in addition to those what were ordered. Wrong dosage form error. Administration of a drug product to the patient in a different dosage from that was ordered by the prescriber. Wrong drug preparation error. Drug product incorrectly formulated or manipulated before administration. Wrong administration technique error. Inappropriate procedure or improper technique in the administration of a drug. Deteriorated drug error. Administration of a drug that has expired or for which the physical or chemical dosage from integrity has been compromised. Monitoring error. Failure to review a prescribed regimen for appropriateness and detection of problems or failure to use appropriate clinical or laboratory data for adequate assessment of patient response to prescribed therapy. Compliance error. Inappropriate patient behavior regarding adherence to a prescribed medication regimen. Another error. Any medication error that does not fall into one of above predefined categories. Strategies to prevent medication errors. And let's go over them by each step. Prescribing. Avoid unnecessary medications by adhering to conservative prescribing principles. Computerized provider order entry, especially when paired with clinical decision support systems. Medication reconciliation at times of transitions in care. And what is the concept of conservative prescribing? Think beyond drugs. Seek non-drug alternative first. Consider potentially treatable underlying causes of problems rather than just treating symptoms with drugs. Look for opportunities for prevention rather than focusing on treating symptoms or advanced disease. Use the test of time as diagnostic and therapeutic trial whenever possible. Practice more strategic prescribing. Use only a few drugs and learn to use them well. Avoid frequent switching to new drugs without clear, compelling, evidence-based reasons. Be skeptical about individualizing therapy. Whenever possible, start treatment with only one drug at a time. Maintain heightened vigilance regarding adverse events. Have a high index of suspicion for adverse drug effects. Educate patients about possible adverse effects to ensure that they are recognized as early as possible. Be alert to clues that you may be treating or risking withdrawal symptoms. Work with patients for a more deliberative shared agenda. Do not hastily succumb to patients' requests for drugs, especially drugs they have heard advertised. Avoid mistakenly prescribing additional drugs for refractory problems, failing to appreciate the potential for patient non-adherence. Discontinue treatment with drugs that are not working or are no longer needed. Work with patients' desires to be conservative with medications. Consider long-term broader effects. Think beyond short-term beneficial drug effects to consider long-term benefits and risks. Look for opportunities to improve prescribing systems, changes that can make prescribing and medication use safer. Approach new drugs and new indications cautiously. Learn about new drugs and new indications from trustworthy, unbiased sources. Do not rush to use newly marketed drugs. Be certain that the drug improves actual patient-centered clinical outcomes rather than just treating or masking a surrogate marker. Be vigilant about indications. Beware of selective reporting of studies. Transcribing. Computerized provider order entry to eliminate handwriting errors. Dispensing. Clinical pharmacists to oversee medication dispensing process. Use the tall man lettering and other strategies to minimize confusion between look-alike and sound-alike medications. Tall man lettering. The tall man lettering is a technique that uses uppercase lettering to help differentiate look-alike drug names. For example, in tall man lettering, prednisone and prednisolone should be written prednisone and prednisolone, respectively. Administration. Adherence to 5 rights of medication safety. Barcode medication administration to ensure medications are given to the correct patient. Minimize interruptions to allow nurses to administer medications safely. Smart infusion pumps for intravenous infusions. Patient dedication and revised medication labels to improve patient comprehension of administration instructions. The Five Rights.